We are here for one purpose, and that is to educate both healthcare providers as well as patients who are suffering from age-related macular degeneration. We have a very robust program of webinars now because of the pandemic, and this is just one in a series of such webinars. Today we have two very interesting speakers that we think you're going to learn a great deal from. Anyway, thank you for joining us. Tell you a little bit about the Macular Degeneration Association. We're a nonprofit, tax exempt under federal guidelines, and our main purpose is to educate, is education and empowerment, particularly with people with AMD. I want to also thank our sponsors, Regeneron and Novartis, for their support of these virtual programs, and particularly Notovision, you will hear from later, that is a sponsor of our program. We have two very distinguished speakers today. I'll introduce them right before they speak. Our first speaker is a distinguished member of the Macular Degeneration Association Medical Board. Her name is Pamela Webber. Dr. Webber is board certified ophthalmologist and experienced in the treatment of macular degeneration, as well as other macular issues. Dr. Webber was voted Castle Connolly Top Doctors in 2008 and is currently the owner of Island Retina, with offices located in Shirley and Comac, New York. Dr. Webber will be answering your questions after her presentation. And it's now my pleasure to present to you Dr. Pamela Webber.
Hello, Larry, and thank you so much for inviting me. It's really a pleasure to speak on behalf of the Macular Degeneration Association. So today what we want to talk about is AMD research. What's the process? What's on the horizon? And what's realistic? I have some disclosures. I have been a speaker or a consultant or involved with the following companies: Allegro, Allergan, Arctic, Chengdu, Clearside, Roche, Genentech, Graybug, Macular Degeneration Association, Notovision, Novartis, Opthea, and Regeneron. My affiliation with the above will not influence the content of this talk. Okay, excuse me, I just have to, good. Okay, so if you have AMD, and I assume most of my audience does or knows somebody that does, you're not alone. And I always tell my patients that if you have to have a disease, this is not a bad one to have because it only involves the eye, unlike diabetes. And the thing about it is when you have a common disease, lots and lots of research happens and things move very quickly to provide better treatments and better outcomes. So AMD is the leading cause of blindness among people over the age of 50, and the numbers are pretty staggering. In the United States, just in the United States, there's 11 million people with this disease, and about 1 million have the more serious form of the disease called neovascular AMD, or what's commonly known as wet AMD. So who's at risk? Well, you know, it's interesting now with all this genetic testing, we can find out who's at risk. And I, of course, did the genetic testing on myself and found out that I'm a carrier of 2 of the genes, which puts me at higher risk. So this journey to learn as much as I could about AMD for my patients has now become somewhat of a personal journey. So let me share with you some of the stuff I have learned. Macular degeneration always starts out as the dry form. And what we notice, the way we make the diagnosis is we see these little yellow spots in the macula, in the retina, which are very characteristic of dry AMD. And that's kind of the hallmark of this disease. So dry AMD can progress to wet AMD in about 10% of the cases. And wet AMD is a very different ballgame. It can take away vision very quickly, and the treatment is very different. Now, you may have heard from your doctor that you have advanced dry AMD or something like that. And what that means is as the number and size of drusen increase, we start to say that there's advancement of the disease process. And the problem is that even with dry AMD, you can lose vision because the retina gets thin and the cells actually drop out. And that's called atrophy. And you may hear your doctor talk about atrophy. So just quickly to review, just so we know what we're talking about here. So this is the eye, and the cornea is the clear covering. And then we have the anterior chamber and the iris, which is the colored part of the iris. The pupil is what we look through. The lens is right here, and it's hung with little zonules so that it's right in the middle. And then as light comes in, it goes through the vitreous and lands in the back of the eye on the macula. So the macula is a subdivision of the retina, and the very, very, very center is called the fovea. So the retina continues all the way around, and it's very thin. It's like a piece of silk. So the disease that we're dealing with is small. The actual area that is usually involved in the macula is only about 1.5 millimeters in size. So everything we do is really microscopic. Now, Optos is a really good way to image the eye, and I like this because it gives patients an idea of what we're talking about. So again, this is the front of the eye, and as we go through, we're talking about the back of the eye, which is right here, and that's the macula. So the macula is a really unique part of the retina because it gives us our very, very best vision, the vision we really care about, because that's the vision we use for reading and driving. It also allows us to see color, and it's extremely thin at the center. Now, there are many diseases that affect the macula, not just age-related macular degeneration. And here is a really nice picture of the drusen. This is a fundus photo, and you can see these tiny little spots, and those are drusen. You can also see some pigment modeling, and that's another problem that we have. So this is the optic nerve, this is the macula, this is the fovea, and these are the blood vessels that nourish the retina. The bigger, thicker ones are veins, and the thinner ones are the arterioles. So as I said, one of the problems with dry AMD, which we're going to discuss at greater length as we go through the lecture, is that you can get areas of dropout. And here you can see the drusen are starting, and here's a more advanced area. And you can see it almost looks like somebody took like a piece of a jigsaw puzzle out of the retina. There's this funny area, and the pigmentation, strangely enough, has caused this little frowning smiley face, and that's exactly kind of right, because what happens is when we lose this much retina, our vision goes down, and that makes us very unhappy. So again, here's the progression. We start out as dry, and then we can see it advance. These are things that we can watch in the office, and then at some point, some patients will turn to wet, and that's when we start to see blood and exudation and a drop in the vision. And here again is a fundus photo. These are done in our office. And you can see these are the back of the eye. Here's a normal looking retina. And you can see the difference with wet AMD. There's this subretinal blood, there's exudation, and it's right dead center. So one of the things we wanted to talk about with this lecture is phases of clinical trials. Here at Island Retina, we do a lot of trials. In fact, we have 4 happening right now, and another one that we're going to start very soon, which I'll talk about as the lecture progresses. So when we talk about phase 1, this is usually obviously the very first part of the trials, and it involves just a few subjects, usually 20 or fewer. And this is really a safety study. It's only a couple weeks long, maybe a couple months, but it's really to see if the drug that we're testing is safe. Once we determine that, we go into phase 2, and that involves a larger number of patients, so usually 20 to 50. And here we start looking at dosing and efficacy, and this can last months. And once we determine, at least get an idea of the dosing and an idea of the efficacy, then we move on to phase 3. Now, this involves a large number of subjects. These are often world studies, so that we involve countries from around the world. And the length is often 2 or more years. And what we do to get FDA approval, this is the phase that you need to get through to get FDA approval. We do 2 sister studies, and they're done simultaneously with different patients enrolled. The protocols are almost exactly the same. And those 2 studies are then analyzed and submitted to the FDA. And based on that, the FDA will decide if they're approved. Now, I have to tell you, many phase 3 studies do not get approved. So these trials are very, very important. But one of the reasons why patients get involved is because, number one, it gives them a chance to use a drug that may end up being approved years before it's approved. And number two, we learn so much and we can advance our treatment. Phase 4, we also do phase 4 studies, and that occurs after FDA approval. And typically this is some sort of a moderate number of subjects, maybe a moderate length of time, 6 months to 1 year. And typically what we're doing is modifying dose, using it on new indications, and maybe modifying the device, perhaps a new syringe to inject or something like that. So you may be wondering, so what are the goals for treating neovascular AMD? Because we do have 4 drugs that we can use right now. But the problem is, as some of you know, is that you require lots of injections and they have to happen very frequently. And that's really what we're trying to do. We're trying to figure out treatment that's less invasive, so longer acting, and maybe if we could replace damaged tissue, that would also be a goal. So brolucizumab, which is called Beovue, is our most recently FDA approved drug. And this was approved in 2019. And it's an inhibitor of anti-VEGF-A. It tends to work better than some of our other drugs because it's a small molecule and is easily absorbed. It is given, unfortunately, as an intraocular injection. But one thing that we have found is that once patients get through an initial dosing of every month for 3 months, many can go to 2 to 3 months treatment. So it's really, really good for certain patients. So the advantages are definitely a reduction in treatment burden. In other words, fewer injections, but maintaining a good visual acuity and sometimes even better anatomical outcomes than with our other drugs. But what we did discover is that there is a disadvantage in that there is increased inflammation, which can sometimes cause some pretty serious vision changes. Now, we looked at our numbers because we had been using this drug, and we found that about 10% of our patients had some sort of inflammation, but most of it was mild and it would just go away. And then, of course, we would have to switch drugs. So it's almost like an allergy to the drug. But about 2% will have more than just a little bit of a visual disturbance and will actually have some problems. So we try to identify patients who might be developing this inflammation. If they develop it, we get them off the drug, we treat them very aggressively. So not every patient can tolerate this. So right now, because of this problem, we usually only use it on patients that are having a really hard time with the other drugs and that they require frequent injections and maybe never dry up. The fluid never goes away. Now, I wanted to tell you about some of the new drugs that are in phase 2 and 3 that we're working on here. There's many, many drugs that are being investigated. So we can't talk about everything today, but I can at least talk about a few. So Comprocept is one of the ones that we're investigating here in my practice. This is an injection in the eye. It is a phase 3. Enrollment is now closed, so we're just wrapping up the 2-year study. It's a long-acting anti-VEGF, and it's already approved in some countries, including China. So the phase 2 trial looked really promising. It looked like it could maintain vision for longer periods of time with fewer injections. So again, we're awaiting the phase 3, but that looks promising for the future and maybe the near future, maybe 2021. Farisa Bob is another very exciting drug. This is in phase 3 study. It's an anti-VEGF and an anti-Ang2. So it blocks 2 of the proteins that are seen to be collecting too much in the eye in this disease. So by blocking these 2 proteins, we're hoping that again, patients can receive fewer injections and maybe can be maintained on a maintenance of a dosing every 4 months or so. The results of this are pending. Enrollment is also closed for this, so we shall see. Another drug that's being investigated now is Eylea, but it's in a different dose. It's a high dose. So we're hoping again with this is phase 2 right now, This is an anti-VEGF-A and PGF. So it blocks two of the proteins that are involved in this inflammatory process that causes the disease. And again, we're hoping that this will lead to less frequent dosing. Opthea is yet another drug. So you can see there's really quite a few drugs that are possibilities for the future. This is a study that we're going to be enrolling in shortly. It is phase 3, and it's a world study, and it's going to be opening around the world. So this is something that if you want to get involved, you can if you have new disease. This is very interesting because it blocks VEGF C and D. So it blocks a new series of proteins that are also very, very involved in this disease process. And it's going to be used in combination with the drugs that block VEGF-A. So this will require 2 injections of either Eylea or Lucentis with the Opthea. But again, it's hoped that ultimately there will be better results with patients requiring less frequent dosing. Now, I wanted to tell you a little bit about Panoptica, because this is an eye drop. And of course, this is what we all kind of want to find. You know, anything that is an injection that isn't an injection would be kind of a big plus in the treatment of this disease. So what we're hoping with Panoptica, and this is right now is in phase 2 study, so it has a ways to go. It would be used in combination with the injections, but we're hoping by putting this topical eye drop in once a day, that we can cut down on the number of injections that people will need. Now, another thing that's happening, which is super interesting, I think, is that there are new delivery systems. So instead of just an injection in the eye, we're trying different things. Now, sunitinib is a very interesting drug. It's an encapsulated drug, and it's injected kind of like a gel. And the gel sits in the bottom of the eye and slowly releases this anti-VEGF drug. And again, with this, it's one injection. It's a long-acting anti-VEGF. We're hoping that maybe patients will only need an injection every 6 months. It's phase 2. Enrollment is now closed, and I'm sure they're designing the phase 3 studies. But in phase 1, 88% of the patients made it 6 months without requiring an additional injection. So that's a big plus. So we're going to follow that and hopefully get involved in further research with this drug. Clearside has developed another technique for injecting. So instead of going right into the back of the eye, we actually inject into the suprachoroidal space. So right behind the wall of the eye, but before you hit retina. So it's not as deep of an injection, and it can pass all the way around the eye through this choroidal space. And an anti-VEGF is being used for this drug. So again, we have to see what happens. Now, the port delivery system, which is referred to as PDS, is Lucentis. And this is a very innovative drug delivery system where we actually take the patient into surgery, and we implant this little device that you see here. It's actually very small. It goes behind the lens in the eye and extends into the posterior segment of the eye. And this is a refillable little bag, and it slowly releases ranibizumab or Lucentis, and hopefully it only needs to be refilled a few times. Now, this is in phase 3 studies. The phase 3 studies are completed, and we should have the final results and maybe FDA approval before the end of 2021. And this is how it looks on the outside of the eye. You can see how the little port is covered with conjunctiva, the white part of the eye, and so you can barely see it. And with the lid in its normal position, you really can't see it at all. So, and what happens is there's this continuous delivery of drug. So there's always a little bit of drug. So now when we inject a lot of drug, and it slowly dissipates over the course of 5 to 6 weeks. But with this, it'll be slowly entered into the eye, diffusing into the posterior segment. So there's always a little bit of drug on board, and we're hoping with this that we can keep the disease under better control. So here again is kind of a picture. You can see how it looks underneath the conjunctiva. You can't see it from the front of the eye unless you kind of really rotate the eye around, and then you can see it. We can put it in patients who've had cataract surgery or not. Now, the really good thing about this is you don't need many injections. However, this does not mean you don't have to follow up with your doctor, because sometimes we do have problems. This can erode. Sometimes the conjunctiva breaks down. Sometimes it erodes into the eye. And so it has to be watched. So even though you're not receiving injections, you will be followed by your ophthalmologist, your retina specialist, to make sure that the port is in good shape. And there are adverse events that happen about 4%. So it's not as safe as just an injection every month, but it is a possible alternative for patients who just hate the injections. So, but like I said, it is an operation in the OR, a one-time operation. And what's interesting, it just gets refilled when you run out of drug, maybe after 6 months or so. It gets refilled right in the office, and we just go right through the port and can reload it with ranibizumab. So that's super interesting and a really new way to approach this disease. Now, I want to move on to another problem with macular degeneration, and that is geographic atrophy. So you can actually have loss of vision without the neovascular form. And what happens is, as I showed you in the beginning of this talk, is cells just start to die out, and when we start to lose retinal cells. So of course we don't see as well. So how do we manage this? Well, right now we're thinking about tissue replacement, if there's some way to replace this damaged tissue. And then of course we want to figure out, if we catch it early, could we just prevent progression? So we're kind of looking at it from two angles. And one of the treatments is stem cell transplantation. Now this is really just something that's being done as research. You have to be very careful that you're in a good study that is identified by our government, because a lot of people are just kind of doing some crazy stuff where they're just injecting RPE cells all over the body, and that just doesn't work. So you want to make sure, if you're going to go this route, that you're involved in a multi-center phased trial. And basically, there's a couple ways of doing this, but we find stem cells, we grow them, and then we put them back in the area of the diseased retina. So the NIH is sponsoring a study. And again, they're using blood cells. There's a couple of different types of cells, and we can get these stem cells. We can get these pluripotent stem cells from blood, and then we can grow them in culture. We can turn them into RPE cells and then stick them back in the retina. So again, very, very early on. Right now, it's being just done in a handful of patients. We have to collect quite a bit more data, but it's a possibility. It's a possibility for the future. We need to support stem cell transplantation. So if you're interested in something like this is for patients who have lost quite a bit of vision. It's not for patients early on in the disease, because, again, we haven't really figured out exactly all the adverse events that can happen with this, but you can go on to this website, clinicaltrial.gov, and search under stem cell transplantation. It will give you the centers that are doing this and that are legitimate studies. So Zymera is a really interesting drug. So one of the things that happens in geographic atrophy is that there is an overactive complement cascade going on. Our complement cascade is an immune system and an innate immune system that we have in our body to fight infection. But sometimes things are askew, and in geographic atrophy, that's what happens. We have too much complement, and it's creating cell damage and death. So by controlling the complement pathway with different complement inhibitors, we're hoping to control this disease. So Zymera is one that's very interesting because part 1 of phase 3 is completed. They're doing another phase 3 trial. So it's pretty far along. And what it shows is that it decreases the rate of progression of the geographic atrophy by 27%. So that's a big plus. If we can slow down the grade so people are not losing vision, this could be great. So again, we're waiting the results from the second phase 3. Unfortunately, it is administered as an injection every month, but it could be an answer to this disease where right now we have no answers. So this is another drug, APL2. And again, this is for geographic atrophy. This is sponsored, it's a phase 3 sponsored by Apellis. And this targets another part of the complement cascade, namely C3. The complement cascade is very complicated with at least 50 proteins, but this is one of them. Again, it's an intraocular injection every month. Enrollment is open, and it slows down the progression of the disease process, hopefully. So again, we're going to watch this very carefully, and hopefully this will give us some answers in the near future. Now, I wanted to tell you a little bit about ALK-001. This is actually a modified form of vitamin A developed by Alkeus. And this is a trial for geographic atrophy. It's in phase 3, and it's a pill. So finally, we have something that's not an injection. And enrollment is open, and this modified vitamin A could also slow down the progression. The phase 2 looked very positive. So again, this is another thing that we're watching very carefully and maybe FDA approved within a year. Now, the other thing that's really interesting is Brimonidine. This is for some of you, you may be using this for treatment of your glaucoma as an eye drop, but this drug company has actually turned it into an injectable little rod, and we inject it into the back of the eye, and it slowly breaks down over the course of 3 months. So again, it would only require one injection, maybe every 3 months. Phase 3 is starting, and enrollment should be opening soon. And it's a neuroprotective drug. So it may slow down the progression, not by affecting the complement cascade, but rather by protecting the cells that are there. So we really talked about a lot of the phase 2, phase 3. I want to kind of go back to the basics. What do you do if you have dry AMD and you haven't gone onto the wet form and you don't have this geographic atrophy? I kind of talked about the really bad stuff in the beginning, but what about you kind of more like newly diagnosed, or you have a family history? What do we do? Well, again, a lot of it is prevention. So we want to think about early detection, genetic testing, nutritional therapy, and light therapy. So let me explore some of this stuff with you. So early detection, right now, Maculogics is a company that has this product out that is used mainly by optometrists for screening. And this is a test that looks for changes in dark adaptation, because we know that one of the first signs of having macular degeneration is having a reduction in dark adaptation. So you put this little device on and get this little test done, and we can screen for patients that look like they're on the road to developing macular degeneration. And this is really important, because then we can really talk about, nutrition and all these other types of screening to help us manage these patients and catch any disease that's happening early. So genetic testing, I did talk about this. This is a swab that's done in the doctor's office. And what's really good about this is it guides our AREDS2 vitamin selection, because we know that some patients really benefit from AREDS2. Some patients, if it need the zinc in AREDS2, some people don't need the zinc. And if they don't need the zinc, it can actually be harmful. So we want to identify patients that can actually be harmed by AREDS2. And thirdly, some patients, it doesn't matter. They can be taking these vitamins, but they're not helping. So you're kind of throwing your money out the window. So we want to break it down into those 3 groups, figure out which one you're in, and then assign the correct AREDS2 vitamin to you. So that's why we do the genetic testing. It also shows us where you are on the spectrum of this disease and how likely it is that you will progress over 2, 5, or 10 years. And again, if we see that it's unlikely you're going to progress, well, gosh, we don't have to see you so often. But if we see that you're high risk, we're going to see you more often and be more aggressive with our management. So it guides us as to how we should manage the patient and not drive you crazy with eye appointments. But then again, if you need them, get you in. So one of the things that I really want to talk about a little bit is 4C Home. And we actually have No Television who's going with us today, so they're going to talk a little bit more. So I'll go over this really quickly. But any patient that I find that is high risk with AMD genetic testing, we suggest that they do home screening for progression with 4C Home. And that's really cool. It's a little device that you look through, and it takes 3 minutes per eye to do the testing, and you play a little game. And if this is read by a computer, it's analyzed by a computer, and if it detects a change in either one of your eyes, they contact me, and we get the patient in right away. We call them up, get them in, and start screening. Now, it may be a false positive. That's okay. We'll do an OCT, figure that out, maybe watch them more carefully because we know that there's maybe something going on, or they may be wet and they may need injections. So this is really, really great. It's really easy. It's really helped us manage these patients. Another thing that's really interesting is home OCT testing. Now, this is also by Notal Vision. It's not out there yet. It's in phase 3. But this could also be helpful where you would actually do the OCT at home. And this can pick up recurrence. I can monitor, the doctor can monitor how you're doing with it and analyze it. If we start to see change, again, we can have you come in. So this is something that we're watching very carefully and could really cut down on the number of visits to the doctor's office without missing anything. Well, this is kind of a fun part of the lecture. And this is, you know, your overall health plays such an important role in every aspect, including the eyes. And keeping a healthy lifestyle, I can't even begin to tell you how important that is. And, you know, exercising and keeping your weight at the correct numbers, and keeping your cholesterol controlled and your blood pressure, all these things really add up. But we can have some fun with the eating. And actually on our website, we do some healthy eating videos and things like that. But I always say this is the perfect dinner. And hey, this is not so bad, right? It's salmon with some dark greens, either, some kale or some Swiss chard or spinach, whatever you like, glass of red wine. Any antioxidants are great. And of course, chocolate, dark chocolate. Why not? Dark chocolate and more of it, and fresh fruit. Antioxidants, these are all things that are loaded in antioxidants. So have some fun with your diet and help your eyes. The Mediterranean diet is also really, really important. There's been reports out that show that it decreases the progression of macular degeneration. So stick to your Mediterranean diet. If you're not on it, try it. It's really, the food is delicious. It's healthy. It helps every aspect of your body, not just your eyes. And milk, dairy products are also helpful. And oranges. I just was talking to one of my patients today who said that, you know, an orange a day keeps the eye doctor away. So eat your oranges. So this is kind of interesting. Light therapy. This is photobiomodulation, PBM. There's 2 companies right now that have these devices. One is Lumathera, and the product is Valida. And it's investigational. It is approved in Europe. It's not really used much here in the United States, but phase 3 testing is going on. And the idea here is that very low level light, monochromatic light emitting diodes can actually increase a part of your eye, the mitochondria, and promote cellular proliferation, cytoprotection, and reduce inflammation. And this is how it looks. There's 2 products. One is one that you just kind of wear in the eye and get this pulsing light for a little bit each day. And the other one is more of a machine that you put your head in and get this pulsating light. And again, not really sure where this takes us, but we're watching this, and it may be for early disease, just when it's detected. The first reports that come out look promising, so we'll see. So this is kind of the menu for the future, and this is just me having some fun. There's a lot of different possibilities in the future. As you can see, we talked about so many different things, and really I just hit the tip of the iceberg. There are many more studies, and if you're in a study and I didn't talk about it, I'm sorry, I just couldn't hit on everything. I can see we're running a little bit low on time, and I want to have some time for questions. But in general, like before we start to see Druzen, but perhaps you have a family history, your mother has it or something, we can start screening you with the Maculogics technology, which looks for problems with dark adaptation and shows us if we start to pick up on that, we may pick up on that before we even see Druzen. And then we know that we need to screen you some more. So then if we do go on to this dry AMD, we want to start the genetic testing right away, get you on the right vitamins, start 4C home monitoring, and maybe start this photobiomodulation. We'll see. And if you happen to go on to neovascularization or the geographic atrophy, we hope we have injections. Maybe we will use the PDS, the implantable port system. We'll continue with OCT home monitoring to cut down on visits to the office. And maybe you'll just see your retina specialist every 6 months for a refill or a new injection of a gel or something. But the future looks really bright. So in conclusion, as you can see, there's a tremendous amount of innovation happening in AMD, and I think it's just so exciting. I'm so happy I'm involved with this. We stay very involved. Like I said, we're doing 4 studies right now. We're going to start another one very soon. And, you know, things get FDA approved and our treatment changes. We learn more every year. And it's just a really exciting time in this field. So if you have the disease, you know, you have to be optimistic because there's lots of stuff coming down the pike. And again, we hope with dry AMD and geographic atrophy that we can find some new treatments for a disease right now that we don't really have any treatments for. So I hope you've enjoyed this lecture, and I'm going to turn it over to questions. Yeah. So the one question that I had was, if you get a subconjunctival hemorrhage or a hemorrhage following the injection, what does that mean? So that's a really good question. So sometimes after you get the injection, you may notice a red spot or a very large red spot on the conjunctiva or the white part of the eye. And that is not something you need to worry about. We see this quite frequently, especially on patients who are on anticoagulation. We never have you stop your anticoagulation because that we don't need to. But if you do get this red spot, which we call subconjunctival hemorrhage, it will clear. It's like a bruise. Doesn't affect the inside of the eye, only the outside of the eye. Usually there's no pain associated with it. And it doesn't reflect on the surgeon's ability to do the injection. It just happens because we can't identify all the different layers of the blood vessels. And this is an invasive procedure. You know, we're putting a needle in the eye. So don't worry about it. It doesn't mean that there's a problem. It doesn't mean that your retinal surgeon is not up to snuff. It just happens. And we try really hard not to let it happen. And we watch carefully and put pressure on the eye if we do see it. But yeah, it happens. My grandfather had dry AMD, then my mother, then me. I was diagnosed in early 40s and I've been taking the vitamins. What is the probability that my 2 daughters will also develop macular degeneration? Should they be getting regular checkups to look for Druzen? I think that this is interesting in that diagnosed early 40s indicates there's something else going on here. Perhaps it was more of a retinal pigment epithelial decompensation associated with central serous, but that would not be characteristic of age-related macular degeneration. Typically, we only make the diagnosis of age-related macular degeneration when you're over the age of 50. So this seems a little more complex to me. Typically, we start screening for macular degeneration at the age of 50. So if your 2 daughters are not over the age of 50, but you developed at 40, they should see a retina specialist and they should be thinking about something else. This is a little off track for macular degeneration. Okay, the next question is, what about implanted mini telescopes? You know, the implanted mini telescopes have not taken off all that well. I don't do them in my practice. I've never seen a patient with one. I know they're done in certain centers, but it does seem like there's a lot of complications associated with it. And I think that people are getting away from that and more going towards corrections with glasses or video cameras or other types of technology. Okay, so I'm taking AREDS 2. I've read that I shouldn't eat dairy products near the time I take the pill, although my doctor did not mention that. Should I space my dairy consumption with my pill taking? If so, how long should I wait? You know, I think that you know, it's probably good to wait a little bit. I don't think it's a really big deal, but we don't really guide our patients too much with that. So I think maybe wait a half an hour, but I don't think it's a really big deal. Is it possible to treat Druzen buildup? You know, it seems like this photomodulation may play a role in decreasing Druzen, but it's still too early. That's in testing right now. So it's a possibility that could be the answer. but you'd have to go into a study and see. So that's something we have to research a little bit more, but it may be possible with that. So genetic testing is not done in every office. If you're interested in it, you should call in advance and see. It hasn't caught on with everybody. It's a little controversial, but I just truly believe in it. So it's something that you really kind of have to call your doctor and ask if they have it. The other way to do it is through 23andMe, but it doesn't give you as much information. Hi, I do have macular degeneration, but I am 21 and I've been getting Avastin. I would like to know if you've heard a similar case in a young person as me. Yeah, so again, when you have it at age 21, you have a different type of macular degeneration. It might be Stargardt's, it might be myopic neovascularization, it might be associated with an inflammatory process, but it's not age-related macular degeneration. It's a different ball game. But Avastin is probably a good choice for you, and that should be helping you. Okay, the next question is, I was diagnosed with early onset AMD and my ophthalmologist found it during a routine contact examination. I am 53 now and my mom is completely blind. Been seeing a retina specialist in Washington, D.C., and the amount of Druzen has increased despite taking AREDS vitamins since I was first diagnosed. Since I am still dry, is there nothing else that can be done to help me keep my vision? Okay, so like I said, the modulated photo testing might help you, but we're not there yet. You could maybe go into a study for that. You need to, again, I would make sure that you're on the right AREDS vitamins and do the genetic testing just to make sure you can benefit from it and whether or not you need zinc or no zinc. It's really important not to smoke. Smoking definitely makes this disease worse. It's really important to have a healthy lifestyle and eat the fruits and vegetables that we talked about earlier, push along antioxidants. And right now, wear your sunglasses when you're outside, but I would stay on top of it. Early diagnosis is really good, and because treatment is much more effective when we catch it early. But hopefully we'll have stuff for you in the future.
I got a question. Do you ever have a patient with wet AMD that responded so well to injections that you took them off all injections and treated them as cured?
Well, okay, so we take them off injections. We never call them cured. So there are many patients who don't require a lot of injections and they go years without needing it. But you're never considered cured at this point. You always have to be watched and screened.
It's now my pleasure to introduce our next speaker, who is actually representing one of our sponsors, but more importantly, she works for a company that is probably one of the most important resources for people with dry macular degeneration. Dr. Blemker is an ocular disease residency trained optometrist who practiced in Nashville, Tennessee for 9 years before she transitioned to industry. She was executive clinical outcome specialist with Bausch & Lomb Surgical for 4 years prior to joining Notovision team a little over 2 years ago, where she currently serves as Director of Clinical Affairs and Professional Relations. I've heard her presentation before. I also I have macular degeneration, and I use the device every day myself. So all that being said, it's now my pleasure to introduce Pam Blemker.
But thanks for the introduction, Larry. And thanks so much to you all for the pleasure of being able to speak to you today. I'm going to pull up my slides here, see if I can start sharing my presentation with you. I know Dr. Webber mentioned No-Tal Vision and 4C Home. I'd like to share a little bit more information with you. Great. I've got it up on the screen now. But just wanted to reiterate some of the very important points that Dr. Webber made in her presentation. So I'd like to further discuss understanding the importance of early detection of wet AMD and how you can play a role in protecting your vision. 4C Home is FDA cleared and it's Medicare covered. It's prescribed by your eye care professional when you have the appropriate level of vision and the appropriate stage of age-related macular degeneration. And it's a form of personalized medicine with the device being used at home in between your regular eye exams. And it's designed to detect metamorphopsia or visual distortion in age-related macular degeneration. As Dr. Webber shared, there are two types of AMD, and it is the leading cause of severe central vision loss in people over the age of 50 years in the United States. So I'd like to share with you information you need to get informed and take charge of your vision. It is chronic, meaning it does not resolve or go away. And AMD is also progressive, which means it tends to worsen over time. And there are these two types, dry and wet, with dry being the slower changing or earlier form of the disease that puts you at risk for developing wet AMD, which is the sudden change or advanced form of the disease. And also, as Dr. Webber had shared, a quick anatomy review, AMD affects the area of the retina called the macula, which is responsible for detailed central vision for activities like reading and driving and seeing faces of those you love clearly. And in dry AMD, these changes occur in the cells of the macula, and those drusen or deposits that she was talking about build up in this area. And these changes or deposits may induce blurry vision. They can cause difficulty seeing sharp details both up close and far away. And again, dry AMD is the slow form of the disease with the changes that you may not notice over time. And most importantly, it puts you at an increased risk of progressing to the wet form of the disease or wet AMD. So over time, the size and number of these deposits or drusen can increase, and this increases your risk of developing that more sight-threatening form of wet AMD. And again, that dry AMD suddenly changes to wet AMD without advance notice. So if you convert to wet AMD, the abnormal blood vessels actually grow under and into the retina. So at the image on the right side of your screen here, in that macular region. And these blood vessels actually leak fluid and they can sometimes bleed without any kind of warning. And so you may not notice these changes until significant vision loss has actually already taken place. And if you convert to wet AMD, this type of significant vision loss is rapid and severe oftentimes, and symptoms can include the images that you see on the screen here with distortion or where straight lines look like they're wavy, if you have dark spots in your vision, or just generally blurry vision overall. And like I said, an example here on the screen. But unlike dry AMD, there are effective treatments for wet AMD. I know Dr. Webber went through these, and they are most effective, just as she had said, when they're administered early on, before your symptoms are ever noticed and before the vision loss has taken place. So they can halt or slow the progression of wet AMD, but they unfortunately cannot restore vision that's already been lost. So once the wet disease starts, it will continue to advance until you receive treatment. And this irreversible damage can actually occur within days to weeks before those symptoms are ever noticed. But how early is early when I use that word as far as detection? Once the symptoms of visual impairment are noticed, where those wavy lines appear or you have dark spots in your vision loss may have already occurred. So the earlier you catch wet AMD, the better chance you have of preserving your vision, and you can maintain your independence and your ability to go about your daily life participating in all kinds of activities that you enjoy. So wet AMD treatments are most effective when the disease is caught early. 4C Home is an early warning system essentially for your eyes. So you use the device at home in between your regular eye exams, and it helps people with dry AMD detect wet AMD before you even notice that those visual changes have occurred. But how does it work? Well, you take a simple daily test that checks for tiny changes in your vision. It takes just a few minutes per eye per day. And then that testing information, that data, is sent to your eye doctor as well as our No Television Diagnostic Clinic, which is the medical provider of 4C Home. And then if a change in test scores is detected, then our diagnostic clinic alerts your doctor, and then your doctor's office will contact you directly to schedule a follow-up visit. The AMSLR grid with which you may be familiar, that's this sheet of paper, this grid over here on the left side of the screen. It was developed in the 1940s, and for a long time it's been recommended as a simple and accessible tool you can use from home to monitor the changes in your vision. But again, by the time you notice distortions on this type of grid, oftentimes significant vision loss has already occurred. So thankfully, this new technology, our 4C Home AMD monitoring program, has been developed to detect tiny changes before your symptoms are noticed and actually reports them to your doctor so you can receive immediate examination and possible treatment. Testing with the 4C Home is very easy. You essentially will turn the device on and then look into the viewfinder to begin the testing. That's the image on the left side of the screen. In the center here, the green circle, you'll see that a bump will briefly appear and then it'll disappear. And the goal is you use the mouse that's provided to click where the bump had appeared, and then you return to the center dot. So you repeat this process as you're doing the test each time. And then that data from each test is sent to our No-Tile Vision Diagnostic Clinic for evaluation, and then that information is provided to your eye doctor. So this regular at-home monitoring is kind of like any other healthy daily habit, like brushing your teeth, and you want to do it every day to help preserve your vision. 4C Home actually allows you to take a proactive approach. You know, there were some great questions about what can I do to protect my vision? Can I be maximizing my treatment and my strategy? And so 4C Home is a great way to do that. And one of our clinical partners will be with you every step of the way. After our No-Tile Vision Diagnostic Clinic receives a referral from your doctor, then our team is going to answer any questions you might have. They'll verify any insurance coverage, benefits, and then ship the device to you. And then once you receive the device, our No-Tile Vision Diagnostic Clinic actually walks you through the setup and the training. And then you and your doctor will continue to receive feedback from our No-Tile Vision Diagnostic Clinic. But before we ever ship the device to you, before you accept the program and decide to move forward, our team is going to be sure to verify your insurance benefits and discuss with you. And so we have low out-of-pocket costs for Medicare patients. Patients with Medicare and a secondary supplement plan could have out-of-pocket costs as low as $0 per month. If you have Medicare and no secondary supplement, then the plan will pay $15. You'll plan to pay $15.03 per month once your yearly Medicare fee-for-service Part B deductible is met. But again, we have a whole team that will go through this, review this with you before you ever decide to move forward with the program, before we ever ship you the device. So once your doctor sends our No-Tile Vision Diagnostic Clinic the order, then you can begin the 4C Home AMD monitoring program. Appropriate candidates for 4C Home have a particular stage of dry AMD and a particular level of vision, which is determined by your doctor. And then you'll continue to test regularly at home. And if any kind of change takes place, then your doctor is going to be alerted and will have you come in for examination. So in summary, the No-Tile Vision Diagnostic Clinic works with your doctor to remotely monitor your dry AMD, helping you to retain functional vision throughout your AMD journey. And I'm, of course, happy to answer any questions you might have. And thank you so much for your attention. Great. It says, my doctor's office doesn't appear to be familiar with 4C Home. If I'm interested in the equipment, what do you recommend? If you would like to call us directly, then you are absolutely welcome to. Of course, we can provide that information for you. Of course, this is something great to bring up with your doctor, that you were able to participate in this program and you received some more information and you'd love to hear more about it from them.
I want to thank Megan for your presentation. I want all the patients to know that are watching that I use it every day. It's probably one of the most important tools you can have to save your vision. But you need to be diagnosed with intermediate dry macular degeneration to be eligible for this device to be used and covered by insurance. So I want to thank Nodal Vision and 4C Home and Megan Lepner for this presentation. And I want to thank everybody else for attending, and please join us for our next event. Have a good day and Please stay safe.